Welcome to our content on burns. This is not an excessively long class. This should be a fairly brief class, but we'll talk about all the concepts that go into burns and the care of the burn patient. You'll see some of our concepts from the beginning of the class, especially those like related to shock and cardiac output and respiratory. You'll see these, come back for the care of the burn patient. So let's go ahead and begin. Here are our objectives. We're going to look at assessments, the phases, the management, a little bit on the rehab, and let's look at the rest of our presentation for today. And in order to understand burns and burn therapy, you really need to go back and think about the functions of the skin and what it does. So when the skin is removed or damaged, the function is no longer there or is impaired. So we see that's a barrier against infection, and indeed one of our major nursing goals for the burn patient is to prevent infection. And it could be for a minor burn, just an infection at the area, to a major burn, sepsis, and then septic shock. The skin prevents loss of fluids, so fluid balances are extremely important, IV therapy. We have body temperature. One of our former graduates worked for a while in the Loyola burn unit, and he said that the big issue about working in the burn unit is the temperature in the air is about 85, and then you have to go in there with full protective garb, so it's very uncomfortable and warm in there. It functions on an excretory and a sensory organ. It assists with vitamin D production with the sun in our skin. And also it's our individual identity. So people recognize us for who we are, especially of the face, through our skin. So let's look at the layers of the skin. This is important information regarding the depth of the burn injury. And your text has a very similar figure in it for our reference. So you can see the layers start with the epidermis, into the dermis, down into the subcutaneous muscles to the bone. So our depth of burn injury starts with the initial burn into the epidermis and almost the top of the burn, top of the dermis, toward there. That would be our first degree. You've all suffered from those. Second degree then is also called partial thickness, and that goes down through quite a bit of the dermis into the hair follicles. And third degree actually goes into and past the nerve endings down toward the muscle. Fourth degree is not seen very often, but it obviously would be deeper than the third degree into the bone and the muscle, so total destruction of that area. The pathophysiology of the burn, the depth is dependent at the time of the exposure and also the temperature of the burn event. And you can see early damage can begin a little above 100 degrees, and that's actually not uncommon for water coming out of the tap. So we have to be careful when we run the hot water, particularly in baths. Who would be our most at-risk population? So always think of the younger and the older. The younger, they're not drawing their own bath, and they could have an individual not paying attention to how hot the water is and then being immersed into a bathtub, and the scald injury would occur. Older people, think about them. If they're running a tub and they have a lot of diabetic neuropathy or just neuropathy, they could easily step into a much too hot tub and subsequently have burns, and at the time not even identify that they're having the burn until another part of their body is immersed in the tub that is more sensitive. Here's our irreversible damage. There's local responses called zones of injuries. We'll look at that in a moment. And then in larger burns, there's systemic responses. And again, we'll look at that. But it is a full body response to a burn, and especially a major burn. Here are the classifications, and we just saw that on the diagram. So the first degree is superficial, and that's just the epidermal layer. So here's some examples. These are sunburns, a brief flash burn, such as a someone's at a barbecue and decides to put a little more barbecue, not barbecue, starter on it, and it flares up, and a person has like pink on the skin closest to the flare up. Hot liquid splashes, so those would all be first degrees. And the one thing that identifies it is the skin is red, but there's no blistering at this area. And you see it can surround areas of deeper burns. So indeed, if there's been a flame or a flash or something that's happened at one area, as you move away from the middle into the periphery, then you have more of a superficial burn show up. Second degree is partial thickness. That's the more, you'll see the underlined terms are the more technical or more accepted terms of the burns. And you can see the nerve endings are exposed, which is why it's very painful. There's blisters that are part of the burn. And here's some examples as well: scalding, touching a heat source. And these can convert to a deeper burn if the second degree becomes infected and then dives a little deeper. Our full thickness burns then are the third degrees, and you can see what is going on there. There's a lot of dermal destruction, even down toward the muscle and bone. We said the fourth degree was where the muscle and bone were involved. It says there's eschar formation, and in fact, if the nerve is deep enough that it's destroyed the nerves, the deepest parts won't be painful, but it's as you move away from the deepest part of the burn to the peripheral areas of the burn, that's extremely painful because the nerves are still there and intact. Eschar formation. Eschar is a hard covering that happens when a burn oozes. If you think about even just a scab, you've tripped and fallen, you've scraped your knee on the ground on the concrete, and it peels off a layer of skin, and then it gets very weepy, which is like the plasma oozing into there. It hardens into a nice hard scab to protect the area. That's good, but eschar is kind of an extreme form of that, where if, say, there's a burn in an area that kind of encompasses an extremity or even the chest, that hard formation from the oozing plasma, when it hardens, it can actually constrict like almost like a cast, and not allow for flexibility or breathing, or can impinge the area to damage circulation and nerve. So we'll look at that in a little bit. All third degrees require skin grafting, and it's not going to resolve on its own. Here's again some more visuals. First degree burn. You can see it takes up to about 10 days. So this individual on the top, this is a typical sunburn. Dry, reddened, it blanches when pressure is applied, healing time a while, and just kind of cool showers or cool applications. Might be some Tylenol for pain relief. Second degree burns, then you can see under this gentleman's arm, there's a lot of you can see the blisters or the moistness under there. It still blanches with pressure, and that's because the vascular components are there and functioning. But it can have different kind of coloring. It's very painful. Anyone who's had a sunburn that's blistered, you have had a second degree burn. And you can see if it's less, it's the deeper, then the longer the healing time. It's quite a few days or weeks to get full healing on a second degree. Here's our third degree. This tissue does not blanch if it's pressed on, which means the vascular, the circulation has been damaged. So you can see that it's got a variety of colors from the burning. Around the burning, there's a lot of edema that shows up. And you can see if this burn then starts to ooze, if it goes all the way around the leg and begins to ooze, and then that hardens, like I said, a real hard, like a hard scab, this could potentially compress this calf and cause problems, especially if more edema shows up. Here's some causes. Now this could be, I can't remember what this was, but I mean, certainly this could be someone's clothes that have caught on fire and then burned that whole area. Immediate medical attention. This is not to be cared for at home, and it does require skin grafting. mentioned zones of injury a few slides ago. So there's zones of injury based on how close the tissue is to the direct burn. So you have zones of coagulation. So that's where the burn has happened. It's like the central area. If you think when we talked about stroke or the brain, as far as that area, central area of the damage for trauma, and then as you move away from there, there's still damage because of the pressure effects and the chemical effects of the damaged cells. That's very similar here, but it moves further from the center based on the heat exposure and then also some of the cellular reactions. So you see the zone of coagulation is like the center of the burn. You get the proteins coagulating. There's a lot of damage to that area. Zone of stasis. We have more damage, but it's like the blood vessels are damaged. This tissue is at risk depending on the post-burn care. If the individual wasn't hydrated enough, if there was breaks in infection control, they could become infected. And then when we get further out, then we have the zone of inflammation or hyperemia. And you can see the blood flow is there and available, but it increases. And this is like, there's good vascularization at the edges to help with healing and to help start the repair process. Again, if the zone of coagulation, though, is a third-degree burn, that is going to need skin grafting. That's not going to heal on its own. Now, there is a phenomenon called burn shock, and a lot of it is due to fluid shifting. So it is a form of like hypovolemic shock, and the team will watch for this for injuries over 25% of the total body surface area, TBSA. So they watch for it when the patient comes in from the beginning of the injury, and you'll see the peak and the duration there. And it's that the fluid starts shifting from intravascular to interstitial, and as it moves out of the vascular area, then that affects your blood pressure, your pulse. That's a hypovolemic situation. And you'll see with the fluids, there are also electrolytes moving around. Proteins are leaking out of the vessels, so it's a big disequilibrium of the vascular components. So it results in hypovolemia. If the burn has been around the face, then we also have to watch for this fluid shifting and edema around the face and therefore the airway. So with any kind of facial or airway threat, the patient typically is intubated. Here's some system effects from burn that we see with burn shock, or we watch for burn shock. You can see there's a release of this catecholamines that can result in some intense vasoconstriction and initial hypertension tachycardia. But then we have the loss of volume too, and then that can result in decreased cardiac output. So they watch the pressures very carefully if they've got a hypertensive issue on their hand, hypotensive. Try not to overtreat, especially the hypertension, if they know that they're losing a lot of fluids. Here's some of the pulmonary system issues that occur right after a burn injury, and a lot of it is inhalation and therefore airway breathing, A and B. And there's a lot of damage that can be caused, even though the person may not have been directly burned. The heat and smoke can damage the airways and cause like a tracheal swelling. So again, airway, and then breathing. If it's a burn that maybe the person's clothes are caught on fire and their whole chest is burned, that whole, again, formation of that eschar can limit the chest wall expansion, and they might need to have an escharotomy. They might need to be intubated. You can see the concern again, as we talked about before, facial swelling. So very, they're very careful with anything that's around the face and the upper body. And typically those people go to burn centers, but we'll look at that criteria again in a little bit. Other systems can also be affected. I mean, these are deep organ systems, but they are going to be affected from the fluid shifting and also the production of those cardiovascular vasoconstriction elements. So you can see there's a decreased perfusion. They're also concerned with, saving the vital organs, so lungs, heart, brain. So again, the renal, hepatic, and GI system might be set aside. So we have to make sure they have really good maps and good perfusion for their kidneys and liver and GI system. So the greatest risk is if there's a delay in the fluid resuscitation. And again, that's all about the map, and it's all about the renal salvage. If not, renal failure, hepatic ischemia, and then potentially ileus. And gastric duodenal ulcers are not uncommon. This is a huge amount of stress on an individual, and I'm assuming you would know which medications an individual will get to prevent gastric or duodenal ulcer formation. So we'll stay with that, or I'll let you use your good background information for that. A few comments about metabolic effect. You can guess that this individual will be hypermetabolic, really need to increase the support for their metabolic needs by proteins, glucose, lots of oxygen consumption. So this is a big event on the body that needs a lot of support, and we'll look at nutrition in a little bit and how to support the metabolic needs of the body. The other concern with the loss of the skin would be the immunologic compromise. So the skin is a barrier, as we've talked about before. This is a barrier form of protection, but also the different chemical mediators that erupt after a burn can suppress the bone marrow. So if that is depressed for a while, then their immunosuppression is going to be depressed. There, you can see their red blood cells are a little shorter on their lifespan, so they'll need to be supported again for their immunologic system. Lots of tumor necrosis factors released from the damaged tissue, and you can see what that does to the immune system as well. So immune infection prevention, again, is a major goal of the burn patient. Types of burns, let's move into that. You can see thermal has flash and flame. Those are very similar, so we can talk about those together. Scald injury, contact injuries, and then a few others. So let's take a peek at these. So thermal, you see a little tiny thermal injury there. Flash and flame injury. If the flame is in an enclosed space, such as a house or a car fire, then we would be concerned also about inhalation injuries. So the intervention would be to extinguish the flame and then use water source to extinguish the flame, unless it's certain kitchen fires. You never throw water on hot grease, and I'm not going to talk about that at all. But you'd have to make sure that you move the patient out of that area with any smoke or flame as well. Our thermal injury most common type is scald, and that's for the reasons I talked about before. The individual that has neuropathies and can't feel, or children, or this could be the child in the kitchen grabbing the handle of the hot boiling water and pulling it down on themselves. So most common, and the severity is really like how long has the exposure been, as we talked about before. If it's mild, then it's run the area under the cool faucet and make sure if you're using anything to cool it down, it's not so cold that you're causing like a frost injury. And then contact injury, so hot metal stoves. This would be Again, a child reaching up and touching a hot burner. It could be someone reaching into an oven that they have a skillet in there and forgetting to put a oven mitt on. So this is a first degree that you see right here. This was a real quick touch, but has resulted in just a damage to the epidermal layer. Chemical injuries then. Lots of chemicals in our home that you might not think about. So in the home, any drain cleaners, any disinfectants, a lot of in the bathroom, washing, those mold and tile, mold and mildew killers, those have a lot of caustic base in there. And you remember from chemistry lab, if you get base on your hand and then immediately feel it, it's very slippery and slimy. So don't keep feeling it, go wash that off. So again, drain cleaners and disinfectants can result in tissue damage. In the industry then, any chemical industry, working with acids, with bases, with organics, and they always have set up, showers and different wash stations. I'm hoping that you remember all that. If you get anything in your eye, you wash, wash, wash. So that should be good information that you brought over from your chemistry days. The severity is kind of the same thing as any burn, length of time, also what kind of chemical and how acidic or basic it is. And the immediate treatment is typically to wash and wash and wash. And as you see, either water or sterile saline. And this is a silver nitrate burn on a hand. And it doesn't look like a third degree. I'm not sure if there's any blisters, but you certainly have some epidermal and probably some dermal damage on this one. Now, this is our electrical injury, so if you don't like the picture, please cover it up. The big thing about electrical burns is you cannot tell what the total body surface area is because the burn runs internally from the area of entry to the area of exit, and the exit is always the area closest to the ground. So you can see the foot. This was a lineman, an electrical lineman, who touched a wire, and the ground, he was standing on the ground, so that's the exit wound to the foot. So it's a lot of internal damage, a lot of nervous system damage, dysrhythmias. They will note the type of the voltage and the voltage to relate to the providers. And then the pathway, if it's just been from the knee to the foot, that's different than from, the top of the head through the foot. Dysrhythmias and neurologic effects. The baby, it's my understanding on this one, if I recall correctly, the baby bit an electrical wire in the house, and that was the burn. Now you can see, I know it looks ugly, but they're not on a ventilator, so that means this was more of a local injury. And not, something needing intubation. The damage can be fairly severe. They will watch the extremities to see if there's swelling and edema. It can actually, damage the muscle groups where they need to be opened up and drained and try to be salvaged. So I'm going to move off of this now. So sorry about that. That's always a distressing visual. Radiation isn't seen too often. A radiation burn would be from industry. It could also be from radiation therapy, and indeed there will be some local burn from radiation therapy. It is expected that the skin will turn pink. They don't take it to a second-degree burn, so any radiation that's received as therapy for oncology patients, it will typically be the pink on the skin. As far as assessing the burn severity, and this identifies if the patient goes to a burn center or can be handled locally. It's what's the size of the burn, and we'll look at the total body surface area shortly. The depth of the burn, so superficial, partial thickness, full thickness. The age of the victim, and then the age also encompasses the medical history. As we get older, is this person on a variety of medications for different disorders and underlying comorbidities. And then the body area, if it's above, the waist, if it's the head and face, they're more likely to be moved to a burn center. The mechanism of injury, so this individual might have a minor burn, but it might have been a trauma, which ended up with a traumatic injury and some burn, and then any other injury sustained during the burn. So if this was an apartment fire and they had to jump out of a window, that would be a major trauma, or could be a major trauma. This is the standard format for calculating total body surface area. This is called the rule of nines. So you see different factors of 9 on this figure here. And this is used for adult burn victims. Children, you have different body proportions. They tend to have a bigger head and lower ratios for the arms and legs and more for the torso. So theirs is different, and we will not cover that here. I will give you a strong hint that this is a calculation that seems to appear on NCLEX quite a bit. So I would definitely know the rule of nines. In actuality, you're not going to get perfect numbers from this, but this is a way of estimating. So to make sure you understand this concept, if you look at this diagram, and say the patient's hair caught on fire and burned like the back of the head, that would be 4.5 for the back of the head. If just the front of one arm was burned, that would be 4.5. The entire arm, then that's going to be 9. You'll count the front and the back. If you total everything up, you're not going to quite get to 100. They do allow 1% for the genital area, but everything else is based on factors of 9s. So take a look at that and just be aware that this is a strongly recommended concept to know, especially for NCLEX. A couple nursing diagnoses. All of it's related to skin integrity for infection, for hypovolemia, and then for breathing patterns, especially if it's near the face. So those are major nursing diagnoses. Let's quick look at the phases of burn treatment. We have the emergent, acute, and rehab. I'm not going to have a lot on rehab, but we'll concentrate on emergent and acute care. So emergent is, as you see, the first 2 days where they're admitted, their severity is assessed, we're aware of burn shock, we know what to expect regarding the different organ systems. Our goals are, airway, breathing, circulation. So airway is always first. And then fluid support is a huge issue. You don't want to have a patient come in with a manageable burn in your burn center and then end up with renal failure. Pain control is essential. We'll see which preferred pain control method is. All of the infection prevention, the thermal regulation. I talked to you that in the burn center, it's warm in every room, and emotional support. Sometimes the rooms don't have any mirrors, and they may discuss with the patient and family and others when to best introduce a mirror depending on the patient. So inhalation injuries, again, this is kind of our emergency care. So when the patient's brought in and assessed, do they actually have burns to the face and below the face and the neck? Are there singed hairs on the eyebrows, the eyelashes? Some patients will come in and around the nose, under the nose and around the mouth, they will actually have like a charcoaly, soot-like deposition around there. Also, when they cough, it's very, a lot of sputum. It's just amazing. And that may be streaked with charcoal or soot. The cough is kind of brassy from the heat. They're hoarse. And then signs of respiratory distress. So intubation has to be thought of quickly because as the edema shows up, they may not be able to intubate the patient. Some complications here. Everything up to pulmonary emboli and ARDS from the damage. So severe if they have inhalation injuries. So nursing management is not only to manage the burn itself, but what other diseases and disorders, what might be showing up by system, were there other injuries associated with the burn. The immediates you see here, airway. Fluids are always instituted, and usually, and lactated ringers is the preferred choice. Hint, hint, that's another favorite of the NCLEX, that what fluid is our best option, and it will be lactated ringers. Now, the fluids are always instituted if it's greater than 10% total body surface area, or less than 10%, but the patient is over 65. So we're really concerned again about kidneys, about liver, about GI. The Parkland formula is in your book, and I'm not holding you to the Parkland formula, but it's developed a long time ago, and it tells individuals at certain points during burn recovery how much fluid to be infused based on their weight, the total body surface area or burn, and they do watch the output as well to make sure the person is being hydrated. So again, I'm not going to hold you to that, but if you hear and practice anything about Parkland, it's easy to look up and access, but I won't be holding you to that. Here's the body, here's the room temperature issue, lots of humidity. It is very unpleasant to be working in that environment. And then in the emergent phase, it's all about initial wound care. They might need NG or Foley depending on their situation. Pain control is always morphine sulfate IV. And then they're given a tetanus shot if they haven't had any recently for prevention. And then, you know, all they can see is your eyes or your glasses or whatever. So always identify yourself, let them know who you are, what's going to happen during your shift, why you're in the room, what you're going to be doing. Answer some questions. If they have questions about their care, what's going on, make sure you're clear with that. And there's some things you're not going to be able to answer, you know, regarding their recovery, regarding what they're going to look like. Those are you know, we're doing the best we can. If they're, you know, quite ill, we want to, you know, do everything well to have you recover, and we'll look into some of those other questions a little later when it's more appropriate. Initial wound care. They usually will clean and debride. Obviously, pain control first with the morphine. And they'll use a sterile gauze to kind of debride the wounds and pull off any debris that might be in the wound. And again, think about, you know, if they have clothes on, their clothes ignited, they're going to have shreds of burned clothing in their wounds. And then make sure the wounds are covered. Sometimes they don't use dressings, they'll just have sterile sheets. Watch for signs and symptoms of infection. If hair is in the area, it's clipped, it's not shaved. Remember, we don't shave anymore. That just puts little nicks into the skin, so it's clippers. Cultures taken, and there might be quite a few cultures. And then photos as well. And sometimes they'll have the little like ruler or the scale next to the wound. Much, much better to have photos. It used to be, you know, you'd have these irregular wounds and burns, and people would be trying to say it's semi-oval shaped and it's this long and this wide and this deep, and no, photos are where it's at. The Escher formation I talked to you about, if the entire trunk has been burned and that hard scab forms around the chest, they could have problems with breathing. If it's around the neck, that could certainly compress circulation to the head. Extremities, it could have a cast-like effect, so you would be looking at like the most peripheral area you can access to see if they've got good CMS. I am going to show, I'm not sure if it's the next one, I think it is, an escherotomy, which is another icky picture. So if it's not this one, it'll be coming up shortly, but you'll see kind of how the Escher looks Sometimes I compare it to if you have a dog and you go into the pet store, they have those pig ears that are dehydrated, whatever, and they're really hard. That's kind of what eschar is, that really hard, just, used to be a serous protein that's hardened. So let's take a look. So this is an escharotomy, and you can see that eschar is this hard surface, and in the escharotomy you can see that strip of the eschar, or the hard scab, that's been removed so it doesn't compress the extremity. This is I believe this is an arm. So the escharotomy is done. The patient doesn't really require anesthesia because this is a real deep wound, and it can bleed quite a bit, which is actually kind of good. That means that tissue's been released. So they watch that the tissue stays released. It's gonna harden up again, but most of the edema at this point is resolving, so they shouldn't have the tourniquet type of effect. So you can see the torso issues. They release the soft tissue, so the edema is not damaging nerves and circulation, and they may require a transfusion. So let me move off of this. So after the urgent care, or the emergency care, now we have acute care. And this is, acute care includes all of the skin grafting, the treatment of the wound, monitoring the labs, making sure that their status is stable. But a lot of this is the plastics, or the skin graft. So let's look at some of this. During acute phase, we have just the wound care. You can see these. We want to keep the swelling down, so if possible, keep the burned extremities elevated. If it's a facial burn, then head of the bed up. Here's our goals. They can use hydrotherapy to help kind of soften the tissue and the scarring and remove debris. Also, if they put topical medications on after a while, you do want to get rid of the excess. Eschar that's not all the way around an extremity or a body part, as that scabbing needs to come off, the hydrotherapy or tub or shower helps with that. And the shower isn't really a shower, it's a spray table where they can lay on the table and have a gentle spray on them. There's some medications during acute phase. They could either have them open or closed regarding dressings, but there are some superficial, like topical antibiotics that can provide barrier and a little bit of antibiotic treatment to prevent infection. So you can see bacitracin, and if you've used that before, it's just in a tube, so it's like it's an ointment. And then they can use, those are good for superficial burns because of its ointment characteristic. But if it's more of a full thickness burn, they can go to that silver sulfadiazine or Silvadine. I'm assuming some of you have used it. It's kind of a thick white paste, and you put that on areas of cellulitis or burns. It used to be really, people would really slap it on and be on there pretty thick, but the person could actually be absorbing silver, and they absorb some of the medication from there. So now they're saying to only put a thin film of the Silvadine on, so no excess is absorbed through the skin. The other topical medication, there should be a separate bullet point, would be enzymes. And they can use enzymes on some of the dead tissue and debris, and it kind of removes it, digests it, and helps with the healing. For skin grafts, they can use those pretty quickly, especially if it's a big extensive burn, because they don't want them losing a lot of fluid, and they don't want them dehydrating, and they want to protect the area as well. So they can use a temporary skin graft, and then after a while then they would go to more permanent. So you can see the temporary protects the wound, and they can use the If the individual has plenty of skin that hasn't been burned, then they could use an autograft. And that's when we want to get into a permanent skin graft. Temporaries can be cadaver. Temporaries can also be you have it below there, homograft or heterograft, like a pig skin. And as you see on the right, lower right, they actually can culture some biosynthetic epithelium and use that to cover and protect. Now the autografts from the burn patient, they would select an area of the body where they have a kind of a longer area that they can peel skin from. And I hate to say it that way, but that's what they do. So they would peel skin off of a healthy area and put it onto the burned area. And then they would also have to make sure the area they peel the skin from, they can't go too deep on that, but then they have to care for that as an open wound at all. So they can do split thickness autograft or full thickness, and again, the care of the areas afterward are different. With skin grafts, they could either take the piece of skin and then what they would do is like slice it into sections, like postage stamps. You'll see that in the next slide or two. Your book has all kinds of very, very explicit pictures of burns and skin grafts if you want to refer to that. So they have this postage stamp kind of pattern, and they put the postage stamps a little further along to allow for the skin to heal and fill in the area that's not completely covered. They could also, now what they do that I think is a very interesting idea, they take this strip of skin they pulled from the patient and they actually run it through a mesher that puts little tiny punctures in it, and then they can stretch this out like a little mesh. And it can go from, if it's a 3x6 inch, it can expand and cover even a bigger area. So let me stop talking and show you this. So on the upper left, you see the graft being removed from healthy skin. And they typically use like the back of an arm, the back of a leg, above the buttocks, the back. Then they run it through a mesher, and you can see how they puncture it, and then they can expand that piece of skin to fit a bigger area. The other thing is the scarring looks better. It appears as kind of like dimpling. You see the postage stamp method then, upper right, and you can see those areas that don't have covering in between the postage stamps, those fill in. And then you get kind of this quilt-like pattern as the skin heals. The epithelial autografts, then you see that below. It's been applied on this individual skin to protect an area. So I will get off of this slide. A big part of acute phase is just infection prevention. So careful infection prevention. A lot of pain control. You see there's our H2 inhibitors. You can also use PPIs. A lot of topical or systemic antibiotics as needed. Nutritional support, very variable, but we really want to make sure they have plenty of protein, lots of energy through carbohydrates, a good percentage of fat, lots of vitamins, and you can see the total calories can be as high as 5,000. So the average size male uses about 2,000 calories a day, and that'd be a healthy young male with a lot of activity. So you can see that's double the recommended daily allowance for a young male. Comfort, again, morphine before changes, before dressing, before activities. Fluids, range of motion to minimize contractures, that's real important. So your team is going to be the nutritionist, they're going to be the physical therapy, occupational therapy, social service. There can be a psychologist on the team as well. Keep the patient involved with the plan of care. We've already talked about hypothermia. Now rehab. So after the acute phase, after most of the skin grafts are being done, it doesn't mean all of them are, they still will be finalizing skin grafts in this phase. But They will be usually coming off their topical and their oral and their IV medications. More reconstructive procedures is needed. So all the temporaries are done during acute. Some of the permanent skin grafts are started and then they continue. Good dietary intake for healing. Activity as able, especially if like the extremities are involved. Activity really would need a lot of physical therapy. And then scarring. They do have a Jobst garment, and I'll show you one of those that are worn. Additional information regarding activity. So if they've had severe burns, they may have lost like the digits on their feet and then their hands. So we have to do a lot of range of motion to keep them as active and as mobile as possible. Splints are very helpful. They're custom made for each patient to make sure they retain their movement and their position and their normal appearance as much as possible. And you see some of the interventions there. Exercise and ambulation. And again, they're very individualized, dependent on the burn and the recovery and how the patient is progressing, the age of the patient as well. And finally, here's our Jobst garment. So the TED hose, whenever you've tried putting TED hose on people, you know how tight it is and almost what a struggle is to get TED hose on people. But for Jobst garments, these are even more pressurized. So these are tough to get on. You can see that the Jobst garment, the full garment, would be for like a full body burn, or much of the body being burned. And these are worn, as it says, 23 hours a day for at least 6 months. So you can see there's sleeves, there's leggings, there's trunk. For facial burns, they have like this balaclava or facial Jobst garment they would wear. And this is concerning because if they've had their face burned and they're younger, they're kids at school that are going to ask lots of questions. And it helps if someone prepares the class and the school for someone coming back after a burn to help them be kind of reassimilated into the classes. So it's applied for controlled constant pressure to help reduce scarring and leave the tissue a little more soft and pliable. And that is our content on burns. And this ends our discussion on burns and burn care. So bring your questions and we can talk about those in class. Otherwise, have a good day. Bye now.